The idea for today is that we go through some activities related to the COVID-19 pandemic. Our original idea when we proposed this workshop was to invite the NLP community from Switzerland and see what give the opportunity to present all the different activities that have been done in relation to the COVID-19 pandemic. I have to say, however, that we didn't have much response to our call. So we decided instead to organize the event as a sequence of presentations. In the first one, I will introduce NLP activities that have been done worldwide in relation to the COVID-19 pandemic. And this will be followed by presentation from some colleagues of mine, and Patrick Ruch, co-organizer from HESO Geneva. And we have one external person also presenting activities on analyzing patient response to the pandemic and the personal experiences that people have made in the pandemic through narratives. So I think now we are about 20 participants. We might be able to start. Okay, so let's see if we can go through this first introduction of activities. This is a survey compiled about activities, the most important activities worldwide in relation to COVID pandemic through NLP. Of course, our focus is NLP, and so we want to see how and what NLP could do and has done in relation to the COVID-19 pandemic. So I start with an introduction, a quick survey, most important activities, some initiative of the NLP communities, and then I focus on two different types of applications, the scientific literature and then social media. So let's go. So why NLP for COVID-19? Well, there are different purposes, but the pressing question is find quickly information for scientific purposes, for clinical purposes. So scientific purposes, I mean scientists, for example, develop new vaccines, need to find information that is being published about COVID-19 and related coronaviruses, and need to find it quickly and efficiently. Clinical purposes, I mean doctors that have to treat patients, they also need to find information efficiently and quickly. And this information is flowing fast. The public is also interested in finding information. This is a big change and enormous that has an enormous impact on everybody, and people are worried. People want to know more. So can we help them to find answers to their questions? Then we can have more general questions. For example, we might be interested in finding from a social science perspective how people are reacting to the pandemic. Politicians might be interested in finding what's the impact of the policies on the pandemic policies on the population. Another very important topic is to fight misinformation. Misinformation is spreading very fast in this situation, and it's essential that we do something about this. Okay, so type of questions that biomedical researchers might have is how infectious the virus is, what are the most relevant symptoms, which patients are most at risk, what are the biological mechanisms of the virus, how to manage patients, which treatments are most effective. This is a question from both scientific, biological researchers and clinical researchers, those that I just mentioned. Now, public administrators also have a lot of questions. How to select effective public health policies, how to make them acceptable to the public. How is the public going to react to them, or how is it reacting to them? The public, people want to know what is their own COVID risk. This, of course, was totally unknown one year and a half ago. We were all surprised by this. Nobody knew anything. And so we all had a lot of questions. How to protect ourselves, when to be tested, what to do when positive, and what risks are associated with activities. So these are all important questions that different actors have in relation to the pandemic. So the scientific community is trying to provide answers to this question, but the scientific process is typically very slow. Yeah, in this diagram, you see that time necessary that has been necessary in the past to develop vaccines for major diseases. So, for example, typhoid fever first was shown in 1980 that there was a pathogen causing the disease, and the vaccine was only developed in 1 century later. For polio, it took from 1910 approximately to 1950, 1960. And so recently the process been faster, but still it has taken several years before going from the emergence of the pathogen to the vaccine. In the case of SARS-CoV-2, COVID-19, the process has been accelerated enormously. As you can see at the last point, it has taken only approximately 1 year, which is amazingly fast. In relation to the disease, to the COVID-19 disease, we also have seen an emergence of phenomena that has been termed an infodemic. And by infodemic, various actors mean the enormous quantity of information, some of it positive, but a lot of it also negative, has been put into the public domain as a consequence of the pandemic. So with this nice picture, for example, in this publication, they show scientists being submerged by papers taking the famous Japanese image as a starting point. And but this is not true only for scientists. Also, we as the public have been submerged by information coming from different media. Social media are plentiful of information about COVID-19, what to do about that, how to deal with all of that. So what can do NLP to help? Well, NLP can help to find information to scientific literature in the electronic records, patients. It can help to detect trends and opinions in social media. It can help to study the dissemination of information through social media. So the possible techniques, tools, and roles that NLP can assume in this, so we have all researchers and practitioners of NLP familiar with these techniques: information retrieval, question answering, literature analysis, text mining, and transformation of text into computable knowledge, creating knowledge bases, social media analysis, fact checking to combat misinformation. All of these are very, very important roles that we as a community can play. So let's see the major initiatives that have been taken by the community. So first of all, corpora of literature have been collected and curated specifically for the relevance for COVID-19. LickCovid is the most well-known one. Is maintained by the National Library of Medicine, the US organization which distributes also PubMed, which is the most important repository of biomedical literature. They created a curated literature hub about COVID-19. That means they select papers. They are probably a semi-automated process that selects papers that are relevant for COVID-19 and publish in a dedicated website. We'll see a bit more in a moment. Then an initiative to help find information. For example, track COVID. That's an evaluation challenge where participants had to compete and share resources to find information relevant for COVID-19 in the scientific literature. There have been attempts to collect the efforts of the community through workshops. For example, there has been an NLP for COVID-19 workshop organized at the major NLP conferences at ACL 2020, was in June last year, in NLP 2020, which was in October last year, November last year. And so this was 2 episodes of the same workshop, same organizers, where basically were overwhelmed actually by the number of submissions, the number of NLP practitioners and researchers wanted to contribute to this effort. Then another corpus, very important in this domain, is the COVID-19 corpus, COVID-19 Open Research Dataset. That's the name of the corpus, which was an initiative started by the scientific office of the White House and carried on by various scientific institutions, particularly prominent the Allen AI Research Institute. And also an initiative by the EU called MLEI, COVID-19 Multilingual Information Access Initiative. So let's quickly see briefly through this. LitCovid. LitCovid is, as I mentioned, is a repository of, can you see still my slides? Can everybody still see my slides?
Yes.
Okay, thank you, sorry. A second, it disappeared from my screen. Okay, so LitCovid is a repository of scientific literature, biomedical publications maintained by the National Library of Medicine, NLM, in Washington. So the NLM has the institutional mandate to maintain and distribute biomedical literature. In this case, they curated literature specific for related to the COVID-19 pandemic. At the last check, it contained more than 80,000 articles. Actually, no, I think this number is already outdated. Last time I checked, it was 130,000 articles related to PubMed. So there is so PubMed provides abstracts of all articles, and for most of them, it's possible also to access the full text of the article. One interesting event that has happened in relation to the pandemic, that most publishers have agreed to release the full text of their papers as soon as possible, and not hide it under paywalls, as it is often customers with commercial publishing, often typical with commercial publishers. So, and this has been a positive initiative that has helped the research. To most of them, actually haven't given these papers away for free permanently. They just say they make them available for the time of the pandemic. Okay, and another interesting aspect of LitCovid is that it's classified in categories. So the papers are classified in categories that are particularly relevant for research. So you have, for example, clinical research or specific subcategories, and you can browse the collection also take into account these categories. Now, another initiative that has been important is the TREC challenge. So TREC is a competition, a challenge on information retrieval, that is finding text papers in this case relevant for a given topic, and they organized a challenge, a specific challenge on finding papers relevant for COVID-19 through different queries. Of course, the point is always to find papers that match a given query. I mentioned the NLP COVID-19 workshop at the ACL 2020 and at EMNLP. There was again a moment of aggregation of the community. Yeah, we have some of the key themes that have been discussed at these workshops. So biomedical text mining, information retrieval, extraction, exploration, visualization, clinical data analysis, public health. It's also an important topic. Is the public reacting in the present situation? So there's initiative trying to find from what people are saying, for example, in social media, what are their reaction to the situation. Again, the reaction of the public and to the pandemic through different techniques. One of them, for example, is a speech detection. A speech is a problem that has been constant in social media. In the pandemic, we have seen it emerge even stronger. I speech against those who have different political opinion often. That very often the scientific point of view has been overwhelmed by people expressing their opinion without any foundation. And then we have resources for COVID-19, like those that I mentioned before, with COVID, COVID-19. And now we come to perhaps the most important of those initiatives that have taken place over the last year, since the beginning of the pandemic, the COVID-19 Open Research Dataset, which is an initiative started by the White House Office of Science and Technology Policy in March 2020. So basically, they asked research institutes to help find information relevant to the pandemic. And the starting point was to collect all research publications that had something to do, were somehow relevant to COVID-19, but also to related coronavirus, because remember, in March 2020, the pandemic had just started. There weren't yet that many papers on COVID-19. So COVID-19 collected papers also on all related coronaviruses. We had, for example, the SARS-CoV-1 pandemic 10 years ago, if I remember correctly, and so the research done then might have been relevant. So the goals were to create a COVID-19 literature resource, freely accessible, to enable advanced research in NLP, and to generate new insights in support of the ongoing fight against COVID-19. The collection at the moment holds more than 200,000 published articles and preprints, including studies of coronavirus in the past. So how is this being used then in research? So these research institutes got together and collected this collection. So the problems were, of course, different formats, legacy formats, PDFs, for example, copyrights, making them accessible as always means overcoming copyrights, so asking the publishers permissions to distribute those articles. So there were a number of technical and practical problems to solve in order to create this collection and make it available to researchers. But then once they succeed in this, how it has been used? Well, what is the main thing that has happened is that there's been a challenge on Kaggle where participants, which could have been research groups, but also individual researchers or anyone with some interest in NLP, to contribute in solving, or actually not solving, but providing answers to a number of important questions related to the virus. You see on the left here some of these questions that were proposed to the participants. What is known about transmission, incubation, environmental stability? What do we know about COVID-19 risk factors, and so on and so forth? So this was an online challenge to Kaggle, so participants could compare their results, and they were also asked to publish their code through Jupyter Notebooks. So the entire research coming out of this initiative is now freely available to anyone interested. Now let's look at an example of a possible outcome. There have been many systems that have provided interesting approaches to answer this question. I mentioned just one as an example. So this is called AI-powered literature review. And the idea is that collect answers to the questions that we have seen before and provide them in a tabular format by a combination of machine learning and human curation. So the idea was to have machine learning tools that extract the likely information to those questions from the publications in COVID-19 and then present them in this table and let human experts then review this information. You see an example here, seasonality of the infection, and you see the information is collected from papers. You see the date of the papers. Don't see if you see my mouse moving. You see the information of the paper, the paper, and some text that matches the questions, and some factors that also are relevant to answer the question. For example, if the question is seasonality of the infection, then there are also factors. For example, the relative humidity could be a factor, the temperature could be a factor. So all these have been extracted automatically and, as I said, manually revised. This is actually how the interface looks. You can select one of the questions proposed by the organizers here, and you would get on the left, top left, and then you would get the papers answering these questions. Another example is a summarization of the results. So this is based on the previous one, takes the results of the previous one, takes the papers and most relevant to answer questions, like the one we have seen before, seasonality of the infection, and generate automatically a summary of those papers. In project can generate actually multilingual. You can see English, Chinese, Japanese, and Korean. And it's based on the most recent tools. So BERT for the question answering, BART for the summary modules, and then some visualization. So this is a nice example of how NLP can help in, or has helped in to scientists to find information more efficiently. Now the final initiative I wanted to mention is the Multilingual Information Access Initiative, the EU, which is an information retrieval initiative but multilingual. And it has already been at the first round in last autumn and with a workshop in January. And there is a second round starting right now. Actually, I think it's today, that's the official starting date. The goal is to create resources and tools to improve information access through this common goal initiative. So it's of course it's a voluntary participation, and the idea is to cover all official EU languages. Okay, so that was a quick overview of most important initiatives. Now, some of the tools that have come out recently and not so recently about NLP applications. So as I mentioned, the Allen AI Institute has had a prominent role in creating the COVID-19 corpus on which the COVID-19 challenge was based. And they have followed up on this result by providing on their website a number of tools that improve on the results of and build up on the results of the work done on COVID-19. So there is the portal that you can see here. And an example of the tool is this called Spike Chord, which will help to find a relationship between entities mentioned. For example, here's the cause relationship and between SARS-CoV-2. So the idea is to look for causes of SARS-CoV-2 in text. No, sorry, actually, what causes what SARS-CoV-2 can cause as symptoms. For example, it can cause fever, it can cause a dry cough, and so on. Another way, another tool that they provide is SciSight, which visualizes so connections and networks of people working in the area of COVID-19 and their topics. So it's based on topic modeling, and it identifies topics relevant for into COVID-19 research, bundles them, and finds people, the researchers most active in working on them, and then it allows the user to navigate these resources. And final one from Allen AI Institute is SciFact, which shows support for given claims. So you have a claim about coronavirus, for example, coronavirus cannot thrive in warm climate is a claim that has been made a lot in last year, especially. And so you want to find support or refute its claim. And so this is an application that does that, finds sentences in papers that support or refuse a claim. But there have been other tools. For example, IBM has created COVID-19 Navigator. I have another tool from the University of Melbourne, COVID-Z, that also allows navigation of the literature. And of course, there are several others which I don't have the time to discuss. Now, I want to briefly go through some related phenomena, some problems that have emerged, and I realize that my presentation might take a bit more than the half an hour that we have scheduled, but some of the presentations will be very short presentation following. So I think it's okay if I go on about 10 minutes more than originally scheduled. So one phenomenon that has emerged, we have seen in this pandemic, is what I called an infodemic. The enormous numbers of papers have been published relative to COVID-19. We have seen in LitCovid about 2,000 papers per week about COVID-19 only. But the inflation of the literature is not new. It's a phenomenon that has been around for a long time. You see the growth of PubMed, this repository of biomedical literature, historical growth. At the moment, even before the pandemic, about two papers per minute are added on this repository. So this points out to the importance of tools to help researchers navigate through this information more efficiently. There is the problem of citation inflation. That is, this is a problem that has been noted in relation to the pandemic by some researchers. The fact that it has been observed that the pandemic is causing an inflation of citations. The papers are citing themselves, citing circularly very often. There has been also negative aspects. For example, because of papers have been published so fast, the review process has been accelerated. A lot of not very good papers have gone through. There have been major retractions. For example, this paper, which was published in July 2020, the first one, says there have been already 20 papers retracted. That was July 2020, 1 year ago. At this moment, right now, I checked yesterday, 112 papers about COVID-19 have been retracted already 1 year after the beginning of the pandemic. And the source of this is Retraction Watch, a website which monitors this phenomena. So the retraction of papers is not new. A very famous example is the study of 1998 of the reactions, the potential effect of vaccination potentially causing autism. It was a study which was entirely baseless, but it was published in 1998 and retracted only into 2010. In the meantime, this had done enormous damage because a lot of people were using this paper as a basis to create fear for vaccination. And it's unfortunately, the typical reaction of the most fanatical parts of the public, that people most committed to to conspiracy theories is the typical reaction to a retraction is that it reinforces the belief. Instead of taking it as an evidence that the original publication was completely baseless, they take it as evidence of a possible conspiracy against their beliefs. This is a phenomenon which is very unfortunate, but a lot of people, a few people at least, fall into this trap. And so it is very important that the scientific community monitors what is being published and reacts promptly. A phenomenon that's a related phenomenon that's occurred in relation to COVID-19 and where the reaction has been actually quite fast is the Surgisphere scandal in June 2020. So Surgisphere was a company, US-based company, which provided clinical data, patients from hospitals, so at least this is what they said. And they provided to scientists for research also on COVID-19. And a few papers were based on their data. And what happened is then very quickly, it was realized that the data was completely fraudulent. And so 2 major papers were retracted. I have a quick timeline, but I don't have the time to go through this. But it's interesting to see that so the first paper was published in May, 1st of May, 2020. And already on 7th of May, some researchers reacted saying there was something odd with their data. But because the paper was published in a major journal, the New England Journal of Medicine, there were already some public policy reactions. For example, some countries took initiatives in relation to what had been published. For example, Peru include one of the drugs that were proposed in this study, ivermectin, in their guidelines for COVID-19. So you can imagine the terrible impact that fraudulent research can have in a case like this. And then in May 2020, they published another paper against using hydroxychloroquine. And at the time, there was no evidence, neither in favor nor against. So this paper was the major evidence against using hydroxychloroquine. So and so a lot of studies were stopped at that point because this particular paper, this particular study showed that it was not effective. Again, also this paper was shown to be fraudulent based on fake data. In this case, however, the damage was not measured because later research actually then showed that hydroxychloroquine doesn't have any particular benefit for COVID-19 patients. Anyway, they were forced to retract this paper and both papers, and the company went out of business. Of course, I don't know if they are being prosecuted now, but it's a great example to show how important is the scientific community monitors these publications for evidence of fraud. And in this case, the fraud was not really in the papers themselves. The fraud was in the data that was used to provide to generate the papers. Okay, let me move on. Problems that are related to the scientific literature, analyzing the scientific literature. Another problem is the constant changes of the names. So we have strains now. Strains were named with abbreviations and numbers like P117, and very recently WHO decided to change the nomenclature. So suddenly you will need to modify our tools to be able to find new names. It's an example of the problems. One initiative that has been done here in Switzerland to deal with the problem of terminology in related to COVID-19 is COVOC, or COVID-19 vocabulary. And my colleague Patrick Ruch, I think, will mention this in his presentation later. So I move on now. And another phenomenon that we see is the fact that scientific papers are increasingly being cited in social media by social media users. This is a phenomenon which was quite rare before the pandemic, but it has increased enormously. So, for example, the COVID-19 papers published in 2020 got 10 times as many mentions in social media than all scientific publication in the first 5 months of 2019. So there is also a great interest of the public into scientific research. Now, one must distinguish here because it might not be the public at large that is being the originator of these tweets. It could actually be scientists that mention other scientists. So scientists have taken to social media a lot to quickly distribute their research outcomes, and so there might be debates among scientists also that we are observing here. And for example, the Surgisphere scandal that I mentioned before emerged also and became very prominent through discussions in social media. So now this is a good point to switch to the final topic, social media. And I have a few slides that I actually prepared for another presentation that discuss some historical background. I just quickly go through them and then we'll finish with the importance of NLP social media processing, also in the case of COVID-19. So this is, of course, not the first time we see a major pandemic. 1918, influenza is a well-known case. In that case, we had three big waves of pandemic, which is the same phenomenon actually we are seeing right now. We have been just through the second major wave, and we hope not to get the third wave thanks to vaccination. Now, there was also another pandemic, the flu before that, 1889, 1819, Asian flu, Russian flu pandemic, and killed about 1 million people. And you see this nice cartoon from a newspaper, French newspaper of the time. And you see that people profiting from, people celebrating somehow the profits that they can make by selling remedies against the disease. And one of them here is quinine. This is a compound found in trees that has been used for a few centuries already, and previously it was used by the indigenous people of South America to treat malaria. It acts against fever. In 1934, there was a synthetic form developed, chloroquine, and in 1950, another version, hydroxychloroquine. So it's very curious, I think, that we see exactly the same thing that's happening in this pandemic, where people have been promoting this drug without any scientific evidence. At the point when Trump and Bolsonaro promoted the usage of the drug, there was no scientific, solid scientific evidence. And in fact, later research has showed that there are no benefits of this drug for treatment of COVID-19. And the effect that we are seeing of these actions of these politicians is that, in fact, that this drug has been so much discussed in the media, is that the sales of the drug have risen enormously. So maybe there is some strategy behind this. And so it's important, I think, to try to analyze social media, to see if there is some hidden policy agenda behind this. Now, the problem that we have right now is vaccine hesitancy, the fact that people are not necessarily confident of taking a vaccine. And this is, again, nothing new. Already when the first vaccine was developed in the late 18th century against smallpox, the vaccine was actually a derivative of the cowpox virus, because it was served the people having cowpox infection were not susceptible to smallpox. And so you see, and so it derived from cows, basically. And that's also why we have the name vaccine, which is from the same Latin root as cow. And you see this cartoon from that period, 2 centuries ago, more than 2 centuries ago, where people basically have irrational fears about taking these vaccines. Satirical representation, of course. And the same we see now, basically, exactly the same. People have irrational fears about taking the vaccine. And so what we can do as NLP practitioners is to help analyzing social media, finding trends and trying to contrast those trends, these negative trends. The WHO has launched an initiative trying to stop the negative information being spread through social media. Yeah, another research done in Switzerland by the same group as the next presenter. So the group of Nicola Biller-Adorno in biomedical ethics at the University of Zurich, where they shown that to analyzing social media, that the rise of anti-vaccination movement, spreading misinformation. They showed that the supporters, anti-vaccination supporters, are much more engaged in social media than those that are in favor of vaccination, which of course create the echo chamber. They have a strong impact on the public at large, and there are major, and also show there are major influencers in this network. For example, Donald Trump was one of them before he was banned from Twitter. Another example of a study on social media is showed that there are deliberate attempts of manipulate public opinion by not only fanatics spreading the information to their own research, but also using automated bots. And so there must be some agent, some actor that is a powerful actor that has some interest in spreading this misinformation. Now an example of positive research in social media on COVID-19 is this is by the group of Juan Banda at the University of Georgia. And this showed that analyzing through social media, we can find discussion of patients that have had COVID-19. We can find the symptoms of long COVID. Symptoms that are frequently reported by people. And so that's a kind of statistical survey that is much cheaper to to perform than actually asking millions of people what their symptoms are. Now, in the rest of this workshop, we will see some contribution of my own group, the group of Patrick Ruch, and another group on dealing with these problems. And I think this is a good point for terminating this presentation, which was far too long, much longer than I expected, than I had planned. I'm sorry about that. I hope it was interesting. Thank you. So if we have, we can have a few minutes now for questions before we move to the next one. So unfortunately, I'm also the chairman of this of this event, so it's a bit difficult now to. But anyway, so anyone who would like to ask a couple of questions before we move on?
Yes, thank you for the presentation. Actually, I have one question about getting feedback from, let's say, the scientists that actually use the NLP tool. So there's a lot of tasks and tools that come out, and is there some knowledge about what the scientists actually used later on, or what kind of solutions that they preferred or could integrate into their, let's say, daily job or something like that?
That's a very good question, and a question that we all been asking ourselves. There are no clear, I'm not aware of any study or any result that show, but there is anecdotal evidence, and some of the resources that I mentioned that are undoubtedly used. For example, LitCovid is obviously used because it's and one of the reasons why it's so widely used is that the organization that provides it is already trusted by the biomedical researchers. So it's the National Library of Medicine, also produces PubMed, so an organization that is well trusted, is a source that has already been used for decades by biomedical researchers. So that's a resource that can be used and yes. Some of the tools are a lot more experimental. I think that those that probably have more chances of success is those that have some organization some big organization behind. And among those, for example, the Allen AI tools seem very promising. But again, we have to see how things develop. I have to say that there's big interest of the major IT companies in the health sectors, not only related to COVID-19, but more in general. So Google and Facebook even trying to move in, Apple are all trying to move into the health sector. They have all some major unit which we haven't seen much yet coming out, but they are all doing a lot of work in the health sector, collecting data and trying to promote initiatives to get the public using their tools, maybe their apps for health purposes or initiatives. And so I think that some of the tools that we've seen here, some of them are research tools, but the commercial versions of those tools will certainly be used very, very soon. And we will see much more frequently.
Okay, thanks.
Okay, since I'm anyone else? Because since I'm the chairman of an event, as always the task of asking questions to the presenters, but in this case, obviously I cannot do it. So I think if there is no question, we move immediately to the next presentation. Giovanni, are you available?
Yes, I'm here. Hello.
Okay, can you take the screen?
Yes.
Let's see.
My screen. It should work.
Take the screen.
Yes.
Let's see.
My screen. It should work. Okay.
So the next presenter is Giovanni Spitale from the Institute of Biomedical Ethics of the University of Zurich, and he presents one of the aspects that I didn't deal with much. That is how patients are reacting to the situation, to pandemic. What are the personal experiences of the situation? So Giovanni, please.
Exactly. And also a bit beyond patients, because I was trying to decide which of the data sets we are working on to present, and it was tough to decide. So my first choice was to try cramming everything in one presentation, and I hope I will not do a mess, and I will do justice to the data I want to present to you, because they are cool, very cool data. And so my aims for today are basically to present the DeepX International project and dataset, the Publico project and dataset, and then throw some prompts on the table for future perspectives on what we are doing. So first, the DeepX International COVID-19 project. First, a word on what is DeepX. What does DeepX stand for? DeepX means Database of Individual Patient Experiences. It's a research project which started in the UK, and the overall idea in a nutshell is to distill collective stories from individual experiences so that we understand how healthcare works, and we can, on the one hand, provide informational support to patients, families, caregivers, formal and non-formal, and training material for physicians, nurses, and other healthcare professionals. On the other hand, what we collect becomes a wealth of narrative information, of narrative-based information that can be used for instance, bioethical research, which is what I do. And in the DeepX International collaboration, we are now in 14 countries from all over the world, from Brazil to Japan to Switzerland to Australia. We cover 176 different health conditions. So we have research modules on 176 different conditions. We are somehow prolific, meaning that over the past 15 years, we published a total of 250 articles resulting from this material. And what we put online from these interviews on our websites has been accessed I think, more than 7 million times last year. So it's a lot of work. It's nice and it works well. What do we do in practice? We interview people. We ask them. So first we do our homework. We develop a list of questions that becomes an interview guide on a specific condition, targeting the topics we want to study. We interview people, we record these interviews, and then by hand we code this text, and we identify topics that are relevant for this or that area of our discussion, and then we study this material. So when the COVID pandemic started, we started to work on COVID as well, because we have all the capacity and training to address such a topic, which has a lot of social and political implications, as you were discussing before, and to see what people think about this. Patients mostly, but not only. So we pulled and we put together a huge team ranging from the US to Canada. We worked on a joint interview guide, so to have a comparable data across the world. Some of us actually added some bits and pieces to the interview guide that are specific to the situation of the country. For instance, in Brazil, they added questions about spirituality and social inequality, which are big topics apparently in Brazil connected to the COVID pandemic. And we started doing our interviews, and we collected 195 at this point, and more are coming because some of the members are still in the data collection phase, like the UK, for instance, who's aiming for 65 interviews. And yes, I wanted to bring a small sample of the material we collect, and I decided to use a video because it's nice. These are interviews we conducted here in Switzerland, in Ticino actually, with some of the very first COVID patients from the very first wave of the pandemic. So, and I, of course, I've added English subtitles. So here we are. Ci sono due cose che vogliamo fare con questi video. La prima cosa è appunto lo studio delle esperienze di chi ha vissuto questa malattia, e la seconda cosa è realizzare del materiale educativo che verrà reso disponibile con estratti selezionati dell'intervista a altri pazienti, familiari di altri pazienti, medici in formazione, in modo da capire come trattare questa cosa, non solo vedendo quello che c'è scritto sui libri, ma anche sentendo le storie delle persone. Tu hai letto il consenso informato, hai domande da farmi in merito?
No.
Ottimo.
Allora, era il 23 febbraio, ero in Trentino a sciare con la mia famiglia e un'altra famiglia.
Sì.
E appunto sono arrivata il sabato, ho iniziato domenica mattina con un fortissimo mal di gola, fortissimo, come se avessi un fuoco in gola. E durante tutto il periodo non ho mai avuto febbre alta, quindi solo giovedì mattina, cioè quindi ho iniziato questo sintomo la domenica.
E in termini di sensazioni, essendo comunque una psichiatra, devo dire che ho sempre visto la cosa un po' dall'esterno, cercando di analizzare gli altri senza vedere invece quello che poteva succedere dentro di me, sia da un punto di vista mentale che fisico, perché poi effettivamente mi sono fatta 5 giorni con 39,5 di febbre, che era qualcosa che non provavo a livello fisico da credo 10-12 anni.
E verso 10-10:30 di sera è arrivato il responso positivo al Covid, e da lì pronti partenza via per la clinica che è appunto assegnata alla cura di noi appestati 2020.
Però faccio un passo di una settimana prima, perché io ho perso la mamma di Covid. Il 22 marzo, in 48 ore, la mia mamma era ricoverata in una residenza per anziani, e il giovedì 20 l'ho sentita praticamente che stava molto bene. Poi invece il venerdì mattina mi hanno chiamato e mi hanno detto che la mamma aveva avuto sintomi di polmonite.
Ho fatto 2 o 3 giorni, mi ricordo a un certo momento quando ti dicevo che mi mancava il fiato, è perché io psicologicamente in quel momento lì ero fortemente provato. Avevo paura, la mia paura, sai qual era? Che se io vengo a mancare, c'ho entrambe le mie figlie, ancora una 25, l'altra 24 e 22, se questa cosa qua mi succedesse quando loro sono sistemate, cioè le mie preoccupazioni sarebbero sicuramente inferiori, no? E un po' lì ho avuto qualche giorno che ho dovuto utilizzare parecchie risorse per riacquistare sicurezza, no? Cioè essere razionali, no? Cioè, io non ero razionale, stavo male, avevo paura e addirittura cose che abbastanza tipiche per me, penso che quella era una crisi di panico.
No, ai bambini non gli hanno neanche voluto fare il tampone. E quindi tutti un po' molto arrabbiati perché dicono: ma siamo anche amici, dovevate dircelo subito, adesso l'abbiamo preso anche noi, figli, sai, tutto questo panico qui. Io ero all'ospedale, quindi ricevevo dei messaggi ma non ero in grado di rispondere, no? Invece per mio marito è stata un po' più dura, nel senso che anche quando parlava col medico cantonale gli diceva: facciamo tutto noi, ci pensiamo noi, visiamo noi, invece non hanno fatto niente.
Per un momento ho pensato, ho detto, porca miseria, ci siamo salutati un po' di fretta e questa potrebbe essere anche l'ultima volta, visto poi le condizioni Covid, non più visite, no. Ecco, sono stato quell'attimo lì un po'. E poi niente, concentrato sul da farsi.
Non mi è ancora chiaro cosa ci sta dietro a tutta questa cosa, comunque. Non sul virus, ma sulla modalità in cui è stata gestita.
Da una parte, che fortuna abbiamo di vivere in un paese così, no? Voglio dire, penso che in Bangladesh è diverso. Anche semplicemente, almeno al di fuori in Sud America, immagino che vivono delle situazioni che non oso nemmeno pensare cosa sta succedendo, no?
Praticamente io non l'ho più sentita fino al giorno, diciamo, uscito dalle cure intensive, fino al giorno quando ho riportato in reparto, hanno provato a passarmi il telefono e l'unica cosa credo che sono riuscito a pronunciare è: sono stanchissimo. Ecco.
Non riesco proprio a superare questa, sì, magari a volte con la paura che si avvicina la notte, del dolore, o ricordare quelle sofferenze, quei momenti, no, dolorosi che mi stanno tornando in mente adesso. E quindi no, sicuramente mi ha fatto anche bene, devo dire. Grazie.
Ti devo dire che è stato bello comunque avere questo confronto, perché mi ha aiutato a riflettere su tante cose che magari avevo in testa un po' come archè, però ora le ho un po', ecco, esplicitate in modo più conclusivo. Quindi anzi no, ti ringrazio e fammi sapere poi quando c'hai i risultati.
Se no, mi hai fatto sentire molto a mio agio, ma siamo veneti.
Ciao.
Grazie, buon lavoro, buon proseguimento.
Grazie di tutto.
Buona serata allora e tanti
Buona
auguri
serata.
per tutto.
Grazie, ciao.
Ciao, ciao. So this is what we collect, and then this is like the usual workflow on this material. So from a research question, we develop an interview guide. We realize our interviews that become a data set that we study. In this context, being this an international project, we parallelize a bit, meaning that from the same research question, we develop an interview guide, and then we collect multiple sets of interviews that become our data sets, and eventually a joint data set. And for each one of these interviews, we have some metadata, so we know we have information about the interview in itself. We have variables that describe the interviewee, so age, residency, relational status, occupation, educational level, and so on. We have variables to describe the experience, so the setting of healthcare, time of diagnosis, if the patient had long COVID, for instance. And we have what we call codes, what I was mentioning before. And as I was saying, it's a lot of manual effort, especially the coding part, because that means you take material which is structured more or less like this. These are just snippets from the interview transcripts. We put them on the table in a team, and then we keep asking ourselves, why do we think it's important? What are we seeing in this bit of text? What is our own cultural bias in interpreting this part of a narrative? If it's possible to interpret the same material in any other different way, and if the experience is transversal or if it is specific to the context at stake. We saw a lot of these with codes from Brazil, like on social solidarity, spirituality, which were completely new for us in Switzerland, phenomena we were not expecting at all. And yes, so this led to a total of 134 codes, so descriptors that are attached to sections of the interview in the shared branch. So everyone is using these codes in the international collaboration, and then each one of the national teams has a separate branch in which we code stuff which is specific to the context in which we work. I don't know. There's a lot of issues with health insurances in the States, for instance, in the sample we are seeing. And yeah, this is just to put something nice on this slide. The makeup, the kind of and the frequency of codes we are finding at the moment in this bottom-up process. Next step will be to compare all of this material and to draw some conclusion, to form an analysis and to draw some conclusions which are valid on an international level. And this is the data set stemming from the DPEX International COVID project. Now I'm going to rush through this last section of my presentation and introduce you to Publico, which is a different project we are now doing at my institute, which is supported by the WF, the World Health Organization, the Collegium Helveticum, the SNF, and the State Secretariat for Research and Education and Innovation. And Publico stems from a very simple idea. Actually, it's also an old idea. I was in L'Aquila in 2009 when there was the earthquake in Italy, and I was there to help out in that dramatic context. And after the first week in which we were like literally digging people out, we started to have also some administrative duties, like giving information to people. So what kind of papers do I have to fill in if I want to go back to my house and pick up my stuff, for instance? And the background idea for the public protection department was give people the same information, they will behave the same way. Surprise, it doesn't work because people are different. So different people with the same information do not behave in the same way. And that's one part of the idea. Because when you are in a public health crisis, you need first to understand what people think and then to deploy measures that are effective. And to do that, you have it's a double problem. On the one hand, you need to provide information to people. On the other, you need to collect information from people. This kind of risk and crisis communication mostly functions like this. You have an official body which takes some information and delivers it to the public with little or no information about who the public is and what the public thinks about this or that. So you need to overcome somehow this model of one-way communication. And opinion polls are, yes, they are an helpful instrument, but they are not the way to tackle both sides of the problem. So collecting but also providing information likely at the same time on the acute phenomenon at stake. So we had this idea to close the loop, to create an instrument which enables the public to receive personalized information on an acute event, and in doing so provides to the official body at stake information about what people think or believe or how they behave that can be used in defining response strategies which rely on a better view of what reality is. So this was our strategy. On one side, we have the public with this problem of receiving reliable and tailored information on the event at stake. And then our public can go to an online survey or to a collection. And this way we have qualitative and quantitative data about the event at stake. Using the quantitative data, we can provide back information. The same information that is put in the database by the public can be used by policymakers to sense the public opinion, build inquiries that can be as complex as you want to retrieve actionable information. And from this idea, from this conceptual sketch, we developed a full-fledged web app, which works. You can go online and try it by yourself because it's out there, it's public. it's multilingual, first of all, and it's easy. We wanted to have an interface as simple as possible, because this should work also for the elders or for people who are not so IT savvy. So yeah, I really encourage you to go and try it out, because it's fun and it's interesting. And yeah, this is a bit of the tech stuff behind Publico. And here I put some of the ethical features which we consider relevant for Publico, meaning that when you collect information from people, it's always a bit tricky. Who is going to collect this information? What are you going to do with this information? Where is this information going to be stored? Not only in the deployment phase, but already in the design phase, you should plan for these. So, for instance, one thing which I think is quite unique, at least in the current scenario, to our project, is that we involve people from the very beginning. So we had a citizen science approach right from the definition of the survey. We defined doing some text mining on Factiva news articles on COVID and Switzerland. And we did some analysis of Google Trends queries to see what kind of information was available to the public and what kind of information the public was looking for. And with these results, we went to the public asking, look, this is the information we think it's relevant to provide. And to provide this information tailored to your needs, this is the information we need from you. Is it fine to ask these questions? And is this information relevant in your opinion? So yeah, we tried to be nice from the very beginning and considerate from the very beginning of this project. And all of this to say that we are now having results. I ran the first analysis on the pilot of Publico with 163 respondents. Now we have the second version of the survey live. And this is not like really interesting. This is just to say that we can approach people which are younger, but also people which are not that young. We have a good gender balance. We can reach also people who are not Swiss, because we have like a 13% of people who are not Swiss using the tool, and other means everything from German to Italian to Ethiopian. So that's a nice indicator. But what is interesting comes actually at the very end of my deck here. On the quantitative side, we start seeing an interesting phenomenon. So people, we know, we see from the data how polarized the opinions of people can be. And that's from a quantitative point of view. From a qualitative point of view, we have this kind of text. We are able to collect this kind of text. These are just three examples. 62% of our users also leave often a big chunk of text to complement the quantitative data they give us. So they really want us to know what they think. And these are just three examples I prepared for the WHO Infodemic conference 3 weeks ago. So we have everything, literally everything, ranging from people who are kind of fine with the current situation to people who are sick with the situation. So the young adult who's starting to build his identity and life, and really wants to go back to traveling and a normal summer and so on, to stuff for which in Italy you could have trouble with justice. So this sentence, for instance, which I'd like to read: I lost my job, I lost my flat, and soon I'll be leaving from the welfare. Berset and Co are stupid fuckers, blind on both eyes. It took them way too long to focus on children, way too long. It looks as if they have no agenda at all. I start understanding people who believe in a corona conspiracy. Make Berset leave, or I'm sure he will get killed. So this is not like dark social listening, collecting information from hidden groups in Telegram or whatever. This is just what people tell you when you ask them and what do they think, and you provide them and assure them the fact that the data collection is completely anonymous. So it's possible to approach these kind of very critical opinions, which is super interesting. Here I have some references. You will have a link to the slides at the end of the presentation. And concluding, I am much into open science and data sharing as well. That's my conflict of interest. In the community I belong to, there is a sort of resistance against open science, I would say, but we're trying to change and to to grow from this sense, at least at the level of the subjective views of the subjective resistance against data sharing and open science, even when you have personal sensitive information, as we often do, because I mean the rest is kind of easy to address. So our plan is to share this material, the interview guides, the variables, the coding trees, and the metadata from the DeepX dataset. I mean, they're not personal nor sensitive, so there's no issue in sharing this material. The full data sets, we will need to check complete anonymity, because I mean, even in a free text, people can write something like their own name and surname. So we need to check for that. But the plan is to share that as well. And the software, when Publico, now we are still finishing to develop the analytics interface, but when it's done, it will be public as well. And so, as a final word, yeah, we don't have. We don't want to be jealous about our data. We want to have them there out in the wild with like other people to engage also with other methods with our data, also because our methods, as I was explaining, especially about the interview analysis, they cost a lot in terms of time and thus money. So it would be nice to see what other research communities could do with what we have. And that's it. I will now send you the link to download the slides, and my email as well if you want to get in touch about data sharing stuff. So,
thank you, Giovanni. It's very interesting and amazing work, especially I think
they cost a lot in terms of time and thus money. So it would be nice to see what other research communities could do with what we have. And that's it. I will now send you the link to download the slides, and my email as well if you want to get in touch about data sharing stuff. So,
thank you, Giovanni. It's very interesting and amazing work, especially I believe it's especially difficult here to get to the people and get the permissions to release the data, and probably you have to go through a lot of ethical questions in relation to this. But I believe also it's very important to understand what people think and feel about pandemics and the effect it had on them. I don't think we have much time for questions, but if anyone wants to have pressing questions, raise your hand or just unmute yourself and ask. 1 minute. And no. Well, in that case, Giovanni, thanks a lot. But it's certainly very interesting following up and see when you release all the data and discuss ways also in which the process can be made more efficient, maybe with support of more advanced Nlp tools. So that's for future discussions. Now we move to the next presentation, I think, and it's Oskar Likov from my group, who will present an initiative in which I'm involved, but I'm not the main person behind this initiative. It was started as a collaboration. An initiative in which I'm involved, but I'm not the main person behind this initiative. It was started as a collaboration within a group originating in Barcelona, a group in Mexico, and it aims at making the clinical literature of COVID-19 more accessible to the clinicians, especially in Latin American countries. So, Oskar, can you unmute yourself? We see your slides, Oskar, but we don't hear you. I think you're muted, Oskar.
Can you hear me now?
Now we can hear you, yes.
Oh, sorry. Okay, yeah. Today I will present some of the work that our cooperation group has been doing around the COVID-19 pandemic. The project was originally initiated by Mónica Ballesteros, who at the beginning of this project was working for the Hebron Hospital in Barcelona, and Johannes Graham from the Pompeu Fabra University and the Gothenburg University as well. Later on, the team was expanded by collaborators from the Center for Genomic Science from the National Autonomous University of Mexico, and also from the ITSIA lab here at Düsseldorf, which I'm part of it. Why and who? Well, why? Because motivated by the current pandemic, this group got together to work on collecting, organizing, and processing papers related to COVID-19. One of the main purposes is to make the literature more accessible to health workers, in particular to Spanish-speaking countries. And as already stated, the group efforts are integrated by collaborators with different expertise domains and from different institutions. Like, for example, the Swiss AA Lab, the Swiss Institute of Bioinformatics, the Center for Genomic Science from Mexico, the Open University of Catalonia as well, and a lot of volunteer translators. And what? Well, basically, it is a repository where relevant knowledge in relation to COVID-19 is collected, translated, and classified in different areas of medical specialties, and that is mainly to respond to the need for updated information. It integrates some tasks like collecting relevant documents, manual and automatic classification, interlink documents, and also some semi-automatic translation to Spanish. Some of the important features of this repository are that, for example, contrasting with the lead COVID dataset and the COVID-19 open research dataset, the CORE-19, this repository is not limited only to scientific articles, but it also includes some documents that are relevant to health workers, like, for example, clinical practice guidelines. These are not so frequently updated because the effort needed to do that, but they are, some of them, they are there in the repository. Also, another important feature is that all the abstracts have been translated to Spanish to facilitate the search and the exploration process of Spanish-speaking users. And this is very important because even though most clinicians are probably very comfortable with literature in English, it's also the case that other health workers could need to put more time to search and to read in English. So this repository facilitates this first access step. For example, if a nurse wants to search for any updated practice guides related to his job, he can search and read through the abstract more quickly in his native language, and then after this pre-selection he could put a little bit more time to read the selected documents in English or even translate them. But the first step was already facilitated by this kind of approach. What about the potential users that we envisage? They are like health professionals, decision makers, stakeholders, biomedical researchers as well, computational linguistics, and translators. And now I'm going to go a little bit deeper into some of the NLP features that are integrated or used in this repository. First, document classification. So basically, the articles, the documents are classified, taking into account the precept scheme. This precept scheme is a framework whose main purpose is to guide experts to evaluate and grade scientific evidence specific to infection diseases and epidemiologies and so on. And the schema provides a grading way to grade the documents in 4 domains mainly. In disease burden, risk factors, diagnostics, and intervention. So the clinician experts within the group use this precept scheme, and with that they developed a taxonomy to classify the documents in the repository. So the documents are mainly classified in three big categories. There are clinical specialties, where we have 28 classes, types of studies, where we have 5 topics and subtopics, with 10 and 27 classes correspondingly. This is a graphical way to show this classification, this taxonomy. I know it's very tiny, the font, but basically are the broad categories that I already mentioned, and it's just to give an intuition about the classification taxonomy. For example, in the clinical specialties category, we have classes like cardiology, surgery, etc. In the types category, we have intervention studies, systematic reviews, narrative reviews, and so on. And in topics and subtopics, for example, for topics, we have prevention and control and interventions. And within interventions, some of the subtopics relevant to this pandemic are antivirals and chloroquine, for example. So, okay. Very soon, was evident that an entirely manual classification was not an option due to the number of publications. So the group put some effort to build an assisted classification pipeline, and some of the main challenges that they faced to do that was that we have only some hundreds of label examples for each category and for each class. There were classes with very few examples, where so others were very numerous, and also there were some categories with highly overlapping classes, like for example the topic category. This is just an example of how imbalanced are these categories. For example, at the left, we have an histogram of the labeled documents of specialties, and we can see that, as expected, virology is quite numerous, but there are also much more examples of radiology and oncology than, for example, of urology or pathology. And at the right, we can see that we had very few labeled examples of intervention studies or systematic reviews, for example. And these charts are for topics and subtopics. And about the overlapping classes, these graphs are a two-dimensional representation using TSNN and over the embeddings of keywords from the label documents. So these charts are only to try to exemplify the overlapping within categories. So, for example, the clinical specialties at the left are much discernible than, for example, the topic and subtopics that we can see here. So it's very evident for that here that the topics and subtopics are much more overlapped. And so what the group did to tackle this classification task, they use the title, the medium, that it's mainly the journal, for example, keywords and abstract, and they use them as features, and then the TF, IDF, along with SVD, were applied to these features to come up with some embeddings. And about the estimators, some of the trial algorithms were linear SVMs with stochastic SGD, also SVMs with RBF kernels, and also some naive bias classifiers. Also, some data augmentation was done. Basically, a class embedding was generated based on all the documents of a class, and then using that prototypical embedding, they retrieve all the similar documents from the Elsevier collection, and using that, they use that subset of documents to augment the label dataset. These are the best results for each category, along with the best corresponding model. As you can see, the scores are good for the type category, but only average for the other ones. But we have to consider that it is a difficult task, mainly because we have very few label examples, and also because of the overlapping problem that I already stated. However, it's important to notice that this is part of an assisted pipeline. So in practical terms, it means that after this automatic classification, the list of documents with the selected class and sorted by its classification probability are then passed to a group of medical experts within this collaboration group. So they inspect the results, and doing a kind of binary search over the probabilities, they select a cutoff threshold of probabilities, and only those documents that are below this confident threshold are the ones that are manually verified. The other ones are automatically labeled with the proposed label. So it is also a kind of active learning where the experts are asked to verify those data points, those weak data points. So this is for document classification. The other important part, as I already talked about, was the translation to Spanish. This was initially relevant articles were translated by volunteers. There were almost 90 volunteers that were working on this, translating the documents, most of which have a professional background in translation. Then we switched to a little more automatic translation pipeline, and only the title and the abstract were translated. And also during the first stage of the translation, the volunteers were using some tools to keep track of the translation memories. So these translation memories were later on used to retrain some models to improve the translation to Spanish. And yeah, that was mainly the approach to do this. Well, finally, I'm going to present a little bit of what is the sentence interlinking. That it's another model on this clinical repository. So this model, we call it LCOVID, and it's a literature exploration environment, and that goes in two main directions: semantic enrichment, where we are including some name identity recognition and disambiguation, and also some summarization. And also we are proposing a kind of transversal reading strategy for the final users. And this is basically based on connecting similar sentences within the same document or in others, and building a network of semantically connected publications. Yeah, but basically, as I said, there is transversal reading across publications using semantic links. We highlight more central sentences within publications. We also build a graph of semantically connected publications, and all this is based on semantic textual similarity. Using some of the name identities technologies, we highlight the biomedical terms in the documents, and we also power some search for text and named entities within the publication's contents and metadata. Um, so now for each of these subtasks, I'm going to go a little bit deeper. The name identity recognition and disambiguation capabilities are provided by a state-of-the-art biomedical annotator that is called Augur. And Augur, in turn, depends on the Bioterm Hub, which is an aggregator of terms that are sourced from major biomedical databases. And then the semantic textual similarity. For measuring that, we follow the most common approach, that it is generating embeddings that represent each sentence, and then using the cosine among the vectors of as a similarity metric. The embeddings were computed with sentence transformers and using Seibert model, that is a BERT transformer pre-trained model, pre-trained on scientific literature. And yeah, below there is a general view of the system pipeline. So the general steps are first, we process the PDFs to extract the main text. And that means separating the page headers, footers, and the page numbers, and other type of text that is not part of the main narrative of the document. And then also in this step, it's important that we extract some stylographic information, like the text coordinates and some basic styles, because we use them later. Then the second step is to identify the sentences within the extracted text. Next, we do some name identity recognition and disambiguation through Augur API. And after that, we compute all the similarities among all the sentences. And finally, we generate the data. We store all the data in Elasticsearch instance. Yeah, sorry, this is the pipeline. This is a little bit of the STS performance because we didn't have data to evaluate the performance of the semantic similarity. We evaluated in another corpus that we have, that it's about transcriptional regulation, and we got this scores on Pearson and Spearman correlations. This is to give a better sense of what the system looks like. I'm just presenting these screenshots of the main components of the system, of this interlinking component. This is the reading environment. That means that the user can access to the document content here in this type of window. From left to right, we first find the content panel that displays the publication sentences and also the enrichment data. For example, the named entities that are highlighted here in this screenshot. To the right, there is the PDF panel that displays the original PDF when available. And here it's important to mention that this panel is synced with the main panel. So when a sentence is selected in the main panel to the left, the PDF is scrolled to focus, and the sentence is highlighted to approximate. Well, the approximate area is highlighted to let the user know where the original text is in the PDF. And vice versa, the user can also click on the PDF, and the sentences are highlighted in the main panel. And finally, to the right, there is the tool area. The available tools can be activated with the icons, and when active, the tool detail panel is presented. This detail panel have details about the active tool, and for example, here we can see that the activated tool is the name identity tool, and it is shown which name identity types are active with different colors, and we can turn off or turn on the different named entities, and when they are activated, the corresponded identified entities in the main panel are highlighted. And also if in the main panel one of the named entities are selected, then the details of this named entity, and that means the identifier of the within the source databases, are listed here in the detail panel. Now we are seeing this other tool. This is the Interlink tool in the same window. So in the main content panel to the left, the sentence indexes are hyperlinks that when they are clicked, a list of other semantically related sentences within the document and also in other publications is displayed in the detail panel to the right. At the right, we are seeing the sentences related to the selected one. The selected one is the one highlighted in blue. And in the case of intra-document sentences, the list also show the title of the parent document and also the similarity score. When one of the sentences in the list is clicked, the content panel is updated, so the target document is updated and scrolled to focus the target sentence, the new target sentence, and also the interlink list is updated. So the user can seamlessly jump from publication to publication, just following an idea or tracking an idea. So that's the mainly purpose of that tool. And now this is the summarization tool, and it is an extractive summarization. And here, because we were trying to maximize the use of the computer similarities, we try to use them everywhere. So we use them to compute the sentence centrality within the publication. So we use this centrality to rank the sentences, and in that way we can show the X percentage of the most central sentences. So the selected sentences are the most connected sentences with the rest of the publication. When the summarization tool is active, the most relevant sentences are highlighted in the content panel, as we can see here, and also the user can select the percentage of the highlighted sentences using the slider that is in the tool detail panel at the right. And this is we also integrate some search capabilities using or trying to leverage the Elasticsearch capabilities as well. And so the user can search for plain text, but also can search for the other named entities and also a combination of both. And finally, this is a publication network. For each collection of publications, the system can generate a network based on their sentence similarities. It is a directed graph where the color and also the width of the edges are proportional to the number and the strength of the links. So it can be very useful to visually inspect which publications are more interconnected. For example, a review. We expect that a review will be very, very interconnected. But also, it can help us to identify which publications are more isolated. Because then maybe it would be very interesting to review what are those publications saying. You know, why are they so isolated within the collection? The graph is interactive, so the nodes can be selected and moved around. And when a node is selected, its edges are highlighted. So and the main publication metadata is displayed. So the user can, from here, jump directly to the document content, to the main window that we already showed a few slides ago. Okay, and that's all. Thank you very much. As I already said, this was a work and an effort of many people in different expertise and with different expertise and from different institutions. So thank you very much.
Thank you, Oscar, for the presentation. This is a very advanced tool with many different capabilities. Anyone in the public would like to ask questions about what Oscar has presented? So again, here the goal is to increase accessibility of the articles in different ways. Accessibility in browsing the articles, but running different means to access them, through entities, to similarity, various types of navigations, but also accessibility to public in different languages. In this case, we are focused on Spanish and there's a Latin American community. So actually that was the origin of the initiative, the demands of clinical practitioners in Latin American countries to be able to access information from the most recent publication about COVID-19 and how to treat their patients. Obviously, these research results have not yet made into clinical guidelines. So those that faced the situation, the emergency situation, had to check in the literature and find as quickly as possible to relevant information on how to treat patients. And the language barrier can be significant in some cases, and so the semi-automated translations, some was an automated process translation, but some of them were revised manually, was an important support in this case.
Yes, exactly. As Don said before, we don't have factual data about the use of these tools, but we have received some anecdotal evidence that, for example, the translation, as you said, it's very important. It has been very important in some institutions in Central America to facilitate the access to this kind of information. So yeah, it's very true.
Any other question? No, if in the interest of time, since we are very late, I ask Joseph to take the screen and so Oscar, you have to unshare.
Yeah, I'm trying to. Sorry.
Hi, Fabio.
Hi, Joseph. So
I think the whole workshop is only about 20 minutes, right?
No, we can go a little beyond, because the original schedule was till 4:30, so I hope it's not a problem. But if you could just say a couple of words about what you did. It's important to notice that what Joseph was going to present is also going to be presented again on Wednesday in the highlights session. So I asked Joseph not to give a full presentation now, but maybe just tell us in a couple of words what is the important things, what he did, and then whoever's interested can go and see it on Wednesday at 11.
I'm sorry, Fabio, just to let you know, I will have to leave in 10 minutes.
All right, then we switch. Sorry, Patrick, but I was convinced you were available till 4:30. So we give the word then to Patrick, and let Patrick take over. Then at the end of Patrick's presentation, if anyone is interested, we have a look at also what Joseph had to say. Patrick, please.
Yeah, thank you very much. Sorry, I have commitment. Thank you very much. Sorry, I have commitment. So I will surely manage to do that in 15 minutes. No choice. Okay, so I'm going to tell you a few things about COVID triage, which is a search engine we developed at SIB. I think I can stay in this mode because sometimes the slides do not move anymore when I enter into the full screen. So I move to the next one. It's quite, the idea behind COVID triage is very simple. We wanted to develop a triage system to support the curation of various communities, and we didn't know how to start. So what we did is that by sometime in March, already in February, we just decided to open up a Google document, and so that people interested in COVID-19, especially from the biocuration community, could maybe formulate needs. And the way we ask them to formulate needs is by providing descriptors which are important for them. So some people provided descriptors about from the virology world. Some people provided descriptors from the cell lines. Some people provided the descriptors from the biodiversity, and so on and so on. And that was, we thought, a good way to start organizing the realm of COVID-19 to build a future triage system. Okay, so we started with COVOC, which is a controlled vocabulary. But the aim was to organize the literature of COVID-19 in a very bottom-up way, you know, mixing up all those professionals or healthcare or whatever interested into COVID-19. So okay, so we advertised the initiative, you know, with a hackathon and different forum, you know, curation forum, biodiversity, and it was very broad, you know, Twitter, social media. At that time, you have a big sort of I don't know a huge effort towards doing better with COVID-19, whatever it meant. And this is what we ended up having. So we finally managed to organize the content. You see the right one with the disease, with descriptors. Of course, infectious disease is part of it. And then on the left one, you have the big let's say, chapters of the ontology, cell lines, chemicals, trials, disease, and so on, organism, and so on. So we started with the crowd, and then we started to organize it. So one effort to try to organize it was also to cross-reference already existing effort. So of course, if you want to have disease and syndromes, so you can capture the descriptors, but it's much better if you link to ICD-10 or NCI Thesaurus or SNOMED City and so on. And that was one of the big piece of work, was to link with something which was already well established. So we managed to do that for many of them. Sometimes it was very heterogeneous. You see that medical vocabulary, we ended up having like a dozen of them. But for some others, like cell lines, we only had 3 of them, CLO, EFO, and Cellosaurus. Okay. So, and of course, not all of them were one-to-one. So we had to live with a very high number of heterogeneity. Okay, so again, if that was the methods, now if we look at some of the results, so by I think it was May, we had like 443 concepts, about 1,500 synonyms. And we had cross references with at least 20 ontologies, okay? All the well-known from OBO, but also a few others. Okay, that was the first result with the distribution, you know, a lot of biological and medical entities, but also drugs, cell line, and the like, okay? A lot of conceptual entities actually were covered by nobody. I mean, no ontology in the world were covering, for instance, barriers, you know, mask. And you had to look for devices, and that was not trivial. So I go on slide 6. So okay, so of course, once you have the vocabulary, the next step was to try to build the triage system. So the approach that we again explore for the triage is that we decided to cluster the literature with 9 distinct axes. Okay, so these axes were originally emerging from this crowd curation effort that we started with. Okay, so for the formal part of the ontology, we team up with a team at the EBI from Helen Parkinson, and they helped us to structure it. We know with the RDF and the protégé, in particular, the reasoning was a bit tricky. And then we have these 9 distinct axes, okay, in different things. And then we had to annotate the literature so that people can search with a different focus. You can search, if you have a vet, then you have a focus toward the search of COVID information, which are not the same like if you are a nurse or an epidemiologist. So that was the idea, what these 9 axes were relevant to do the search. Of course, we still needed to evaluate, and that was not trivial. But so let's say by summer and spring, the system was online. powered with the SIB literature services, and COVID triage was live, let's say. Okay, I go on. Sorry. Yeah. So what was the result of the annotation? So we processed all Medline, all PubMed Central, actually going through your PMC, but that is not very important. And of course, preprint from Cord 19. Okay, so that was the collection that we had. So from August 2020, that was the number of entities annotated. Huh? Okay, so let's say if you put together Medline, PMC, and Cord 19, of course, some of them here might be overlapping. Huh? So you could end up with about 500,000 annotation. And by spring, so end of April, beginning of May, for all of them, everything was fully annotated into Europe PMC. So if you go now into Europe PMC, all Europe PMC is fully annotated with the COVOC descriptors with cross-references. Okay, this is result number one. Result number two. So one of the challenges was to try to go beyond terminological entities. You know, to normalize name entities with terminology is very useful. You know, you can handle synonyms and so on, but that's not sufficient. So one of the challenges was, for instance, to handle variants. So we developed a specific thread of work to handle, you know, the variant of unknown of concern, you know, of a variant of unknown significance in genomics, or the variant of concern for the virology. Okay, and now you are familiar with it because we all know the delta, alpha, and beta, and I don't know how they will do that when they will have more than the alphabetic Greek number of letters. So this is what we wanted to go further, in particular with variants. So today we have 2 billion annotation into CBILS, which is SIB literature services, and we are moving far away from terminologies because we also annotate variants. I will show it that in the next slide. Now, if we look at the result number 3, which are the search effectiveness of the system. So how good is it to search? That was a problematic question. So we were very lucky because in August 2020, Trek decided to organize an impromptu competition based on the LNAI Cord 19. And they made different cycles of evaluation to develop, let's say, good enough search engine. So we use this collection, which was not necessarily done for triage. So we use the collection in an extrinsic manner, and we evaluated a baseline search engine with or without the aspectual classes of COVOC. So it means that each query was assigned with a set of aspects in the COVOC ontology, and we were boosting the descriptors for this particular aspectual axis or axis in general. So for instance, the idea was that for what is the origin of COVID-19, we assume that the origin was not, let's say, the history, but was the organism or the geographic location of the virus or the disease in that case. And we were lucky because we showed that the improvement with COVOC compared to the baseline Trek were significant. I mean, at the minimum for MAP in the range of 5%, okay, which was a sort of good news for us. I go on. So, so the system was online. It's still online, so you are free to use it, and it's updated daily with PMC and Medline. So this is the GUI. Feel free to use it. We do not have time for playing with it now. You can, of course, choose the axis here that you want to look for. If you want to cultivate cell lines, then you have a different interest than if you are a vet. We go on. Okay. So, of course, all the content is annotated with concepts, so things are normalized. This is, of course, the reason why we developed the tool, and the same apply. This is an abstract, and the same apply to the full text that you can navigate with crossing specific terminologies that you want to see highlighted. Okay. We also have the author's manuscript, by the way, of Medline. So not only the full open access, but also the author's manuscript collection. So the system has been now generalized. So we build the system for several sub-communities, and always with some evaluation of the system. I'm not going to, people of senior were interested into protein-protein interaction with the virus. People from IMEX, kind of the same, and so on and so on. SVIP was interested about the impact on other aspects, and UniProt was interested about virtually everything. Okay, so what we added lately is the work with the variant. So you can now look for the variant. So we have a specific entity for this. It's called variomes. And if you compare with the baseline that exists, I mean, there are not that many for those interested into somatic and germline variant, but one is called LIDVAR, which is maintained by the NCBI. And we have about plus 70% recall compared to LIDVAR. This is a very recall-oriented task. The goal is to find variants that are sometimes very rarely found into the literature. The same for the virus. You have rare variation of the virus. So, okay, you can see all this is online. And actually, it has been released, the bioarchive has been released only 15 days ago, so it's very timely. And we already have more than 1,000 queries daily. So I'm approaching the end of my talk. I promised it won't be more than 15 minutes. So these are some perspective. So of course, if you build an ontology, then you need to think about how to make it sustainable. So we are discussing with the Global Biodata Coalition. But it's still very unsure that we will be funded by them. Of course, we have this, we will increase the interoperability of COVOC. COVOC is now on the ontology lookup service of the EBI, but we want to go further. We would like to work together with other, let's say, OBO contributors, in particular CIDO and the Elixir core database, of course. And we know that we have to improve the consistency of the axes for the next release of the ontology. Okay, we have no deadline for this, but we are working on it. And the next one will be for the biodiversity and vet community will be to monitor the biotic interactions. Okay, this is for sure, because in the meantime, we receive a grant from the European Union, from the H 2020 last call about epidemiology and SARS-CoV-2. And now we are funded for the next 4 years, and we are going to focus, thanks to the BioCycle grant, to look for biotic interaction. So if I recap what we did, so you start with the crowd by March, you have a beta version by June, you have a COVID triage, let's say in July, first version, and then the rest is iterating. And you get the funding only a year after, if you think about it. The kickoff of the project started in May, and so you get funded a long time after that. I mean, you all know it, but I wanted to observe it. So thank you now to the Bicycle Grant, and thank you very much for your attention. I'm happy to answer one question if you have, and thank you very much for the attention.
Thanks a lot, Patrick, for this presentation, which I think also answers a bit a question that Don asked at the beginning after my presentation. That is, do we know if tools are being used? And in this case, we do know, and I think it's because of your close collaboration with many bio-curation groups and your deep integration inside the Swiss Institute of Bioinformatics that basically make your tools available to this group and help to promote them. And so that's a very nice example of the outcome of one of these NLP projects that are actually being used in practice. One question that I have is have you considered or experimented with automatic ways to automatically expand or update the vocabulary. I think there is a lot of manual work that goes into creating the vocabulary. However, there might be ways to come up with suggestions for, if not automatic integration into vocabulary. So there are modern tools can look for synonyms to the most recent deep learning approaches and can do it quite well. Have you considered this? Or,
yeah. So I think in general you are right. So one aspect where we used let's say automatic approach was to match the descriptors into other terminologies. So at least that one we surely made and we controlled, you know, for the with very simple normalization, you know, plural s, stemmer and stuff like that. So we did this work to match the ontology. We did not try to bootstrap the ontology itself, because to start, I mean, I would say that one problem is that today we have an ontology, but a year ago we had 0. So I would say to support the maintaining of an ontology would make sense to use the semi-automatic system. But to start really from scratch, it's very, very hard. Huh? Where would you start? So that's why we started first with the crowd. I mean, to initiate the seeds, I think today the crowd or the expertise is still a must. That is my impression. But in the long run, you're right. Yes.
Thank you. Any question from the public for Patrick before he has to go? And I apologize again for being so late.
Thank you very much. Huh? Thank you very much.
Anybody? No. So I think Patrick has already left us. All right. So originally we had scheduled till 4:30, but we don't need to go to 4:30. We did the most important things. The 2 presentations that we skipped actually are not so important, because one of them is going to be repeated on Wednesday, almost identically, and the other one was about tools that have been mentioned. So, for example, the entity annotation that Oscar mentioned in his presentation, was the main subject of the other presentation. So what we could do very, very briefly, just as appetizer, if Joseph could take the screen and just show briefly the demo of the system, 1 minute or 2. This is an application of social media mining for COVID, Twitter, called the Twitter Monitor, the COVID-19 Twitter Monitor. And as I mentioned, there's going to be a full presentation on Wednesday at 11 in the highlight session. Joseph, would you manage perhaps to share your screen and show us briefly?
Yes, 1 second. Can you see my screen?
Nope. Yeah, now we can see it.
So yeah, just very short. So the main goal in our with the Twitter 19 monitor Twitter COVID-19 monitor is that with a pandemic like COVID-19 pandemic, we cannot expect to have disease-specific data sets, and we also have a lot of different methods in the community, but we normally don't have a way for the broad public to access these methods to find information about emerging diseases. And now with social media, we have a lot of information available about emerging diseases or opinions on these diseases, also research articles that get shared. And our approach is here to pick up information with unsupervised and pre-trained models on other diseases which generalize well, and then apply them so that we can gather information in Twitter about COVID-19. Fabio, so
yes, so I think given that we are so late, that's probably enough. As I said, this is just an appetizer. It's an online tool that actually can be accessed by everybody, and it can be used to browse the Twitter, all tweets about COVID-19, and again, Joseph is going to present it in detail. There are many different capabilities in this tool. You can browse it through different ways and facets, and if you're interested, please see Joseph's presentation on Wednesday 11 highlights session of Swiss Text. Okay, so if you stop sharing, Joseph, now I will just say a few words about the other presentation that we skipped. But the presentation was going to be given by Nico College, who also works with me, but Nico couldn't make it to the workshop, so I would have had to give the presentation myself. And so instead of, but as I mentioned, these are tools that we have already seen in Oscar's presentation. I'm just briefly recap, giving a recap of what this is about. Okay, let me see if I can share this. Oh, sorry. Okay, now I should be seeing a web page where we mentioned the Biotherm app, which is one of the tools that Oscar mentioned in the presentation. As a tool that was initially developed by my group at the University of Zurich, and it's an aggregator of biomedical terminology. So in itself, it's nothing particularly exceptional or interesting, but because it just takes the existing biomedical terminologies from all biomedical databases and collects them into a common vocabulary. However, it's very practical for biomedical text mining tools because it offers a way to keeping these resources constantly up to date. It just monitors the original resources into original databases and allows you to basically get always the most up-to-date version. So if you're building a biomedical text mining tool and you need terminological resources, this is a good point to start. Okay, so this is quick thing. And ways in which we use this is annotation of articles. For example, this is an annotation of an article that, and the annotation is done actually with another tool called Augur, which also Oscar mentioned, and basically it's also originally developed at the University of Zurich and then continued in my new job at ITSEA in Lugano. It started off as a dictionary-based tool, but in recent development, it has been extended and integrated with deep learning methods to improve the quality of the annotation. And basically, the goal is to get annotations like those that you see here in biomedical documents. From the interface, you can send any piece of text to be annotated. You can send a PubMed ID or PubMed Central ID, and you get the annotation of different types that are supported by the system. And actually behind every entity annotated, there are also the corresponding database identifiers. So you know, for example, that the ubiquitinating is a Go term from the gene ontology, and coronavirus is a term from the NCBI taxonomy of species, and you know which one it is, because everyone, I mean, you know, this is visualization, but actually the tool can deliver the results in different formats. It can deliver the results in XML format, in CSV format, and basically you can even do a batch processing of a collection of articles and get the annotations and use it for further process. So this is has been used by, for example, Oscar in the application that he mentioned, and particularly the presentation that Nico had prepared was about using this for COVID-19 pandemic, where we have taken the entire lit COVID repository and annotated it with our own entities and made it available to the research community through different interfaces. Our own interfaces, but you can also get the entire data set as an archive, or it has been uploaded to European PMC in TBI in Cambridge, and to Pub Annotation, which is a similar repository in Japan. So these are sort of baseline tools that can be used to build more powerful applications, like the one that Oscar presented, but also like those that I mentioned in my initial presentation. So tools that, for example, like the LNAI tools are based on similar background approaches. Okay, and with this, I think I've finished what I wanted to mention, what we could want to present today. So I would like to ask the participants if they have any questions now to those that are still here. Unfortunately, Patrick had to leave. And if you think we could organize something similar in future, maybe with involving more people. I mean, what kind of interest is there in contributing with NLP technologies to this particular situation, but also similar situation in the future? The NLP community has reacted very fast, as you've seen in my presentation, and hundreds of tools have been produced. So maybe Switzerland should also be prepared and do more NLP for biomedical approaches and be ready in future situations. So any comments from the public or questions before we conclude? So I have a comment from Fatma, thanks a lot. So we'll make available the presentations to webpage later. So if you want to follow up, feel free to ask questions and try our tools if you want to. We are happy to answer questions. And we also welcome collaborations for future developments. All right, if there are no further, nobody raising their hand or saying something, I think we might have to close the event at this point. All right, so thanks everybody and goodbye.